All right, good morning or afternoon. Welcome to another episode of ICU Doc Talk. Today we're going to talk about ECPR. So what is ECPR? So E, right? E stands for ECMO, and CPR is CPR, cardiopulmonary resuscitation. So ECPR is a shorthand for putting someone on VA ECMO, veno arterial ECMO, while you're doing CPR on them. So basically, it's a last ditch resuscitation effort to save someone's life and to bring them back when they are in cardiac or cardiopulmonary arrest. We're going to talk about the feasibility of doing this, and I'm going to give some examples. This is something that I do in my practice. I make the decision to put someone on ECMO while we're doing chest compressions, while we're running CPR. Let's talk about candidacy. What is the right type of patient to put this on? What is the wrong type of patient to put this on? This is a decision that is often needed to be made very quickly, and it's fraught with complications and bad outcomes, like poor outcomes, complications, and bad choices, right? Because it's a decision that needs to be made quick, and maybe it's not the right decision at the time. So I've probably used it on this podcast, and I always use it in my teaching clinically. And I think I've mentioned on TikToks. There's this. So let's say you're a pilot in a plane, and I always say I don't know anything about flying, so this analogy probably doesn't work that well. But I know nothing about planes. Anyway, so let's say your plane is coming, and it's like on fire or something. It's not doing well, and the pilot needs to land the plane, and they're coming down. They're flying, and they're coming, and they see the runway, and there's only a little bit of runway left, and they either have to land or they have to pull up, and if they keep on the same trajectory, they're going to crash into a bunch of trees, right? So does the pilot, is there enough runway left to land, or are they able to pull up, and can they circle back and try again, or are they going to crash because they're on fire or something like that? So that pilot needs to make a decision to either land the plane or to pull up. And the pilot does not know the future and doesn't actually know what the right decision is because they don't know the future. But that pilot knows that they must make a decision. So they make a decision. And that's kind of what this has to do with, ECPR and just a lot of decision making in critical care and in anesthesia and the surgical world. You have to make decisions on the spot when you may not have all the information and you make a best decision, estimated guess based on experience and on the advice of other people. So that is a lot of the decision making that's with ECPR. Sometimes you just have to make the decision. So let's first talk about let's talk about candidacy. Who's the right person for ECPR to put on VA ECMO while they're in cardiac arrest? All right, so first let's talk about the right candidate for ECPR. By the way, just terminology. Okay, so I know there's people that listen to this that are familiar with ECMO and that are not familiar with ECMO. So let's just back it up with terminology. So ECMO stands for extracorporeal membrane oxygenation. ECMO is a machine that exists outside the body that you hook someone's body up to. You put these big kind of garden hose tubes in their body, and you drain all their blood continuously. You oxygenate it, and you pump it back into their body, and it can help someone recover from heart when their heart is in shock and not working, or if their lungs are not working. So it can act as a lung machine, and it can act as a heart machine, depending on where you put the catheters. That's how it behaves. There's VV ECMO, which is veno-venous ECMO, which is used for hypoxia or someone's lungs that aren't working, but their heart is still working. And then there's VA ECMO, veno-arterial ECMO, which is for when someone's heart is not working. So it bypasses the heart, and it supports the heart, and it replaces the function of the heart while the heart is out or recovering. So that's VA ECMO. And when we're talking about ECPR, remember that's ECMO CPR. That's putting someone on ECMO emergently while they're getting CPR. It's always VA ECMO. You never put someone on VV ECMO during ECPR because you don't always know why someone is in cardiac or cardiopulmonary arrest, and so you just put them on VA ECMO, unless they're coded or whatever because they were in hypoxemic arrest, like they had ARDS or something like that. And then there's also ECLS, which stands for extracorporeal life support. That is used interchangeably with ECMO, ECLS and ECMO. ECLS is VA ECMO, basically. And that's actually the more accurate term, and it's actually the term people should be using is ECLS rather than ECMO, because ECMO just is membrane oxygenation. It really just has the oxygenation component in it. ECLS is extracorporeal life support. It is the more accurate and more precise term. But I find when I use it, it just confuses people because everyone's just used to the term ECMO. So I will use the term ECMO and ECPR. Okay, so let's talk about a patient. So someone arrests, they have cardiac arrest, and you're doing chest compressions and you're trying to get them back. And you're giving them epinephrine and all you're following the ACLS algorithm. Trying to resuscitate someone and trying to get ROSC, right? ROSC stands for return of spontaneous circulation. So you're trying to get them back. Sometimes you can't get people back, right? And ECMO is a way to put them on a heart machine, this machine, that will then take the place of their heart, that will keep their body alive, with the idea that they'll maybe be able to recover from what has caused them to go into cardiac arrest. So that's the idea of putting someone on ECMO during chest compressions, this ECPR. So I get calls when I'm on the ECMO service to assess people for ECPR. Oftentimes the emergency department at my institution will call me to come down and to assess a patient that they're actively resuscitating. So that's someone that I come down and I run right down to assess that patient. Or someone in the operating room is in cardiac arrest, or someone in a different ICU is going to a cardiac arrest. So I'll get called to assess that patient to see if they're a candidate for ECPR. So that's part of my job, is to come in and assess that patient, often with limited information, and to determine if they are a candidate to be put on ECMO. Okay, so what are the things that I think about with candidacy? So there's a couple things, right? There's a couple of absolute contraindications, meaning if I hear any of these one thing, typically, I will not put this patient on ECMO. And I say no, they're not a candidate for ECMO, and I announce that so everyone hears it. And then I'm no longer involved in that patient's care unless they're one of my patients that I'm taking care of also in my ICU. Anyway, so the first one is an unwitnessed arrest. You don't put someone on ECMO if it's an unwitnessed cardiac arrest. Why? So unwitnessed arrest, what does that mean? That means someone came along and found someone who is dead. That's basically what that means. Someone came along and they found someone who was down, and they took their pulse and they didn't have a pulse, and then they called 911, and EMS, the medics came and they started chest compressions. Or maybe the person who found them started chest compressions and then called. And then you're doing chest compressions and you're trying to get that person back. That's what an unwitnessed arrest means. So you don't put someone like that on ECMO. And the reason is that person, it's possible that all that effort is just trying to resuscitate someone who's already dead, a dead body. Because maybe that person died an hour ago or 2 hours ago. And so the whole point of putting on someone in ECMO is things need to be reversible. If someone has irreversible neurological injury, you do not put that person on ECMO. Someone who has an unwitnessed arrest is an automatic no. You do not put them on ECMO. Another absolute contraindication is if their initial rhythm was found to be asystole, meaning flatline. They don't have any electrical activity in their heart. If that's the first thing that was found, you don't put that person on ECMO. Because again, how long have they been down? How long they've had no flow. If they've had a no flow time for like 5 minutes or more, meaning no chest compressions, it's confirmed, like they weren't getting any chest compressions or nothing was done for 5 minutes or more, they're probably not. That's probably an absolute contraindication. You do not put them on ECMO because, again, irreversible brain injury. If they've had CPR for more than 60 minutes, they should probably not be put on ECMO. That is an absolute contraindication, because 60 minutes of CPR. Hey, CPR, even the best CPR in the world, it's still a low flow state. You're still getting not enough blood pressure to your heart and your organs, despite the best CPR in the world, and they probably will have irreversible neurological injury. And there's no point of putting someone in ECMO if they're going to be brain dead. There's no point. Other absolute contraindications are end-stage liver and kidney disease. If someone's on dialysis, if they have liver cirrhosis, end stage, they shouldn't be put on ECMO. Their chances of coming off ECMO are alive, being alive after it, even if you put on is extremely, extremely low, and you are likely prolonging their suffering, and that they will probably die anyway. So those are contraindications. A pre-existing terminal illness with a life expectancy with just like a couple weeks, you don't not put them on ECMO for obvious reasons because they're going to die anyway. And then any other signs of catastrophic central nervous injury of their brain or their spinal cord, and it's not recoverable, non-reversible, you do not put them on ECMO. So those are absolute contraindications for ECPR. So basically, if I hear any of those things, that I decide this patient is not a candidate, and I announce that to everybody and ask if anybody has any problems with that or any other suggestions, and then I leave. I don't participate in that patient's care anymore, unless again they're my own patient that I'm resuscitating. All right. So once they don't have it, if the patients don't have any of absolute contraindications, there's relative contraindications, meaning like, okay, what does that mean, relative? Well, it's up to the situation. It's up to who the people at that moment making the decision. And there's some things that might be relative contraindications, like, well, if they have this, you measure these things together to come to a decision. So some kind of relative contraindications to putting a patient like this on ECLS or ECPR who's currently coding. There's a couple of, there's a few of them, being of older age, right? And by the way, all of this stuff is institutional dependent. So this is not universal. Things I'm sharing here in this episode are not universally accepted. There's variation from country to country and from institution to institution. But I would say the stuff I'm telling you, and then I'm going to continue here, I would say most institutions probably converge mostly around what I'm saying. There's nothing that I'm saying that's crazy, right? I'm not making this stuff up. It's not just my personal opinion. So I would say, on average, most institutions are probably going to agree with mostly what I'm saying. But take that with a grain of salt. And if you work at an academic center that's capable of ECMO, know what your institutional protocols and guidelines are. Anyway, so strong relative contraindications would be like an arrest before EMS showed up in the field. Someone has cardiac arrest, and they arrested before, even if it was witnessed. That could be a strong, if bystanders are doing CPR for 30 minutes before EMS arrives, and then EMS continues chest compressions, and then they come to the emergency department, that's a long time. Again, it's all about what's the low flow state. What is their brain seeing? What blood flow is their brain seeing? Oh yeah, and then older age, right? And I don't personally have a cutoff for that. Generally, we think, greater than 70, greater than 80, certainly not, because it's about life expectancy. And age, it's relative, right? If it's like if someone is 65, if you work in healthcare, or if you don't, someone can be 65 and they look, and their body is the age of, is 20 years older, because of whatever, lifestyle choices, maybe not choices, addiction and things like that. So age is a relative contraindication, but you certainly, I'm not opposed to putting someone on, ECPR in their 70s. I think that would be extreme, meaning they must be a perfect candidate. Otherwise, they must have very, very good health and no other major comorbidities, and a really good chance of recovery. If their cause of arrest is hypoxia, they may not be a good candidate. That might be a relative contraindication, meaning they've been asphyxiated for whatever reason for a long amount of time, because again, they're not getting good oxygen to the brain, and they can have anoxic brain injury. What else? A contraindication to systemic anticoagulation. So typically you need to put someone on anticoagulation when they're on heparin, when they're on ECMO. Usually we put them on something like heparin or a DTI, direct thrombin inhibitor, like agatrobin or bivalirudin. Because running blood through a mechanical circuit can be prothrombotic. So if someone has like a brain bleed you don't put that person on ECMO, or if they have a contraindication for that. And then a BMI, a high BMI, like greater than 45, greater than 50. So this is highly controversial, and I'm aware of this, and I make TikTok videos, and I see all the controversial comments, and I understand the controversy. And I understand the controversy about using BMI to begin with, right? BMI is a very crude measurement of someone's, height and weight. And it's not a measurement of someone's health. And I say that BMI, there does need to be a BMI cutoff for putting someone on ECPR. I'm going to explain why. But I just want to first say that I know BMI is not an indicator of someone's health. Obesity, the higher someone's BMI is, that means they're obese. Some people make the argument you can have a BMI of 40 and not be obese. And that is true, right? You can have a ton of muscle mass and you can be very, very, you can be a super healthy person and have a high BMI. That's extreme and that's not typical. So people who make that argument, I think are making that argument in a little bit of bad faith because that's not typical. If you have a BMI of 45 or higher, I'm pulling this number out of thin air, 99% of the time that person is obese. There's no way, very, very unlikely that person is a bodybuilder. So BMI 45, 50, 60, these are morbidly obese patients. So they have morbid obesity when you have a high BMI. Now what I wanted to say was that BMI is not a indicator of someone's health, but it's an indicator of obesity when it's high. A BMI of 29, maybe that person may not be obese, but a BMI of 45, that person is going to be obese. They're not a bodybuilder. And my point is that with obesity and with high BMI, it becomes higher risk of disease, higher risk of disease like cancer and diabetes and heart disease. Doesn't mean you have those things, but it puts you at higher risk. So having a high BMI and obesity is being in a state of higher risk of having disease. It's not a state of disease, and it's not a state of bad health in and of itself. But let me explain why a high BMI can be a contraindication to ECMO. So there's something called the cardiac index, right? Cardiac output is your stroke volume times your heart rate, right? That's how much output your heart is putting out to your tissues. Now we normalize that with the body surface area into something called the cardiac index, or CI index. And the cardiac index is cardiac output over the total body surface area, BSA. If someone's obese, their BSA, their body surface area, goes up, right? And that's in the denominator of the cardiac index, right? So if someone's body surface area goes up, the cardiac index, the cardiac output must go up to match that body surface area to maintain a cardiac index. So someone with obesity their cardiac output is higher to keep up with the more tissue mass that they have, the adipose tissue, the fat tissue that they have, to deliver blood flow to it. Here's my point: there are limits. So if someone with obesity goes into cardiac arrest, and their heart's not working, if I were to put that person on ECMO, there are limits to how much cardiac you're replacing their own cardiac output and their own cardiac index with the ECMO cardiac index. And there are limits to how much cardiac index you can deliver. As someone becomes more obese, their body mass and their body surface area goes up, but the size of their vessels does not go. The size of their vessels does not grow. It stays exactly the same. So we have the exact same size of catheters, ECMO catheters that we put in. It would be the exact same size you put into someone with a BMI of 20 compared to someone with a BMI of 50. Exact same size. Now there's a limit of how much flow we can get through those catheters. And flow, how much you can flow, that equals how much cardiac index you're able to deliver to someone's body. So when someone has a higher body surface area, they have to have a higher cardiac index to match their metabolic demands, and we cannot match that with the ECMO flow. Additionally, so someone can make the argument, well, why don't you just turn it up? There's limits. You can't turn it up. As you start turning up the pump, you also start hemolyzing your red blood cells, and you just can't. It's very difficult to match their demands of the cardiac output. And then cannulating can be very difficult. People with large pannus, there can be extra tissue that surrounds those cannulas that can limit the flow. So it is challenging. Not only is it challenging, we may not be able to meet someone's metabolic demands when they have a higher BMI. That's why it's a relative contraindication. Generally a BMI of 45 or above. Okay, so what are the big indications to put, perfect indication? So for me, the perfect candidate is someone who is relatively young, and I mean someone in their, 50s, 40s, 30s, right? 20s, obviously. And they have a witnessed arrest, and their initial rhythm was ventricular fibrillation or ventricular tachycardia. Those, or someone with suspected pulmonary embolism. Perfect. That's a great candidate. If I hear those things and chest compressions are ongoing, I activate ECMO and we put that patient on ECMO, because that's something that we can reverse, right? You can reverse a pulmonary embolism. You can reverse often VFib and VTAC, because oftentimes it's cardiac ischemia. It's a heart attack, and you can send someone like that to a cath lab, to the cardiac cath lab, and they can take care of the occlusion in their heart, and then their heart recovers, maybe, hopefully, to some extent, and you can get them off ECMO. And then the other one is hypothermia, right? Classic. Someone who is drowned in a lake. There's clearly neuroprotective effects of being hypothermic. So if someone is hypothermic and that's why they're arresting, definitely a great candidate for ECPR and VA ECMO. All right, now let's say, so that's all the contraindication stuff. Let's talk about putting someone on ECMO in this setting, ECPR. So typically it's good to have someone, it's nice to have someone, a Lucas machine, which is a mechanical device that does chest compressions without a human doing it to free up hands. Now, whoever's running the code, let's say this is happening in an emergency department, whoever's running that code should keep running the code blue, should keep resuscitating. And the ECMO team should do their thing. Now, when you activate ECMO, a lot of people come in. Now, people that need to keep in mind, so if you're not in healthcare and you're listening to this, most hospitals aren't able to do this, right? ECMO. This is a advanced technique in major medical centers around big cities. So most medical centers are not able to do this. It must happen at large medical centers, academic institutions. So anyway, when you proceed to do ECMO, you do femoral. You place the catheters, or you cannulate femorally, right? Because you can't go up top, because you're doing chest compressions, or they're intubating, or they're putting in lines, or whatever. So typically you do it femorally, the femoral artery and the femoral vein. And so when you activate ECMO, the ECMO machine comes, and ECMO specialist comes, or perfusionist comes, and they have the equipment. So I'll scrub in as they're handing me stuff. I prep the legs, and then I gain access to the femoral artery and the femoral vein using Seldinger's technique, which is, if you're familiar, that's just like getting access to any central line, right? You put in using ultrasound, you find the vessel, and you got to use ultrasound. You can't do this. I mean, you can do it blindly. But you're going to confirm it with a transesophageal probe. That's why I say it's mandatory to have a TEE probe, a transesophageal echocardiogram. Someone puts a TEE probe down the throat, down in the esophagus, and looking at the back of the heart, and a cardiologist, usually a cardiology fellow or a cardiologist, is taking a look at the heart. The reason you need that is because as you're cannulating below, putting in the catheters, so I'm looking at the vessels, and I think this is the artery, and I think that's the vein. And you aspirate, Seldinger's technique, you aspirate blood, you thread a wire, and you have that wire now in your vessels. And then you thread an even bigger wire called what we use in my institution is called an Amplatz wire, which is a very long, rigid wire, different from a normal wire that you use for putting central line in. And you thread that wire up the vessels, and then on the TEE probe, the cardiologist, and it doesn't have to be a cardiologist, just someone experienced with using the probe, can confirm that they see the wire on the venous side, like coming up at the bicaval junction, if you're familiar with that terminology, on the venous side, or they're seeing it on the descending aorta. And that confirms that, yes, I am in the right vessel, and I'm going to dilate this vessel, and I'm going to put the different catheters in. The reason that's important is you put different catheters into different vessels, right? You put your outlet, your longer catheter, into the venous side to drain, and you put your outflow, or your out of the circuit, back into the body, onto your arterial side. If you don't get that right, then you're not doing the patient any good. You have to get that right. The return has to come onto the arterial side so that you get retrograde flow back up the aorta, so that you perfuse the organs on the arterial side, right? So you have to get that right. If you don't get that right, you screw that up, you've done the patient nothing but harm and no good. And it happens. It has happened before. Where and that's probably because it was done blind and probably without a transesophageal probe, right? Anyway, so you dilate the hell out of these vessels. You dilate them up to huge dilators. And then because you're putting in usually like a 17 French, a 19 French on the arterial side, or like a 21, 23, 25 French on the venous side, larger size gauge on the venous side, because that's where you're draining blood from, right? So you dilate them up, and then you thread your huge cannulas. Cannula is another word for catheters, down them, and then you get blood. You get blood coming back out. You clamp, and then you get your ECMO tubing. I know I'm probably getting a little bit too into the details here. And you do wet to wet, if you're familiar with that terminology, and you hook up your echo cannulas and you turn on your circuit. You make sure there's no bubbles in there, and you turn on your circuit, make sure you get good flows. And then you can actually stop chest compressions. The other day, I put someone on ECMO, and I was like, okay, stop the Lucas machine. What they were on, I was like, you can stop the Lucas machine. And I think it was an emergency department resident was like, but there's no pulse. And I was like, oh yeah, there's not going to be a pulse. Their heart's not working. We are now giving them blood flow. There's not going to be a pulse. So it's something to keep in mind. So you put these people, so you have them on ECMO once they're a good candidate, and then you got to figure out what to do with them. Why did they arrest? Got to figure that out. Sometimes going right to the cardiac cath lab to see if they have a, to see if they have a heart attack, right? Thrombus in one of their coronary arteries. So I will share a story, and just so you're aware, the stories I share are highly anonymized. I change out a lot of the details, including the gender, and age, and all that stuff, so that these are very anonymized stories. Anyway, so there was a patient. So I was called down to the emergency department for a patient that was relatively young, not young, and not old, relatively young, and it was a witnessed arrest. So this is, and they're doing active chest compressions, and the the ER physician is telling me these details. A witnessed arrest. So I hear that, I'm like, okay, witnessed arrest, relatively young, no other comorbidities, no major medical problems. I'm like, okay, these are sounding good. And as the emergency physician was telling me, they got ROSC, meaning they got the patient's heart rate back, their pulse back. And I was like, okay, well, maybe they don't need ECMO. And then the patient immediately arrested back. So we put the Lucas machine back on. And so I heard those things. Now, they had been doing CPR for 60 minutes, right? That was one of those relative contraindications. Greater than 60 minutes, they may not be a good candidate because they can have irreversible brain injury from being in a low flow state. However, when I was standing there and that patient got their pulse back, they were fighting. They were moving all of their extremities, and they were grimacing. They were moving all their cranial nerves. They were using all their cranial nerves. So I know that person had some intact neurological function. So I made the decision to cannulate, to put that patient on ECMO, which went very well. The typical time course from activation to cannulation should be, a good time is 30 minutes or less. So the cannulation went very well, and we did it as I just described. This patient went to the cath lab, the cardiac cath lab, and had a big lesion in one of their coronary arteries, which they stented, and which was likely the culprit lesion, meaning it's probably what caused the arrest. Unfortunately, that patient started to having a lot of bleeding from their GI tract, and it's like 2 liters in probably about 20 minutes. And that was a combination of being on heparin, right? You give a bolus of heparin when you put someone on ECMO, and then being on antiplatelet therapy after their coronary stent. So that provoked a bleed. And without going too much into the details, the patient had what was looking like a necrotic stomach on a scope when I had the GI team come and take a look, and probably had other gut ischemia from being in a low flow state. And then we scanned the patient's head, and the patient had a large stroke, non-hemorrhagic stroke. So putting all that together, what likely happened is the patient had low flow state for those 60 minutes, had ischemic injury to their organs, including their brain, and then was put on anticoagulation and antiplatelets and had bleeding because of that. So seeing all those things and seeing that the patient probably had irreversible neurological injury, the family decided to withdraw care soon thereafter, and that patient passed away. So, despite all our effort, we did literally everything to save that patient's life. And like a lot of things in critical care, despite our best efforts, it was all for naught. But I think it was still the right decision that we made to put that patient on ECMO. So that was one time it didn't work out for a patient, and other times it does work out. That's why we do it. We wouldn't do this if people didn't survive and they didn't leave the hospital, and they do. Anyway, obviously it's a big topic. Many, many more things I can talk about with that topic, and maybe I will on another episode. You all let me know. All right, we're going to move to the book for this episode. This book is called The Coming of the Third Reich, which is part of a series, The History of the Third Reich, by Richard J. Evans. This is about the rise of Nazi Germany. It's a fantastic historical book. My main takeaway from this book is how dangerous it is to normalize political violence, to normalize ultra-nationalism, and to normalize paramilitary activity. So this was a really phenomenal and accessible historical account of the rise of the Nazi Party from around the turn of the century to 1933, when the Nazi Party finally took control of Germany by legal means, mostly by legal means. It took control by legal means, and then it acted illegal after that. I found the account to be pretty dispassionate and factual, and also very engaging. We get a little bit of historical backdrop of Bismarck and the Second Reich and the ultra-nationalists and the authoritarian roots that were already laid down well before the turn of the century. Roots that endured well and eventually helped support the overthrow of the Weimar Republic, which was the democratic republic that was in Germany at this time. The rise of the Nazi Party took several decades and happened from a combination of happenstance and several other factors. It was a combination of in my opinion, a combination of economic upheaval, military loss in World War I, widespread propaganda, ultra-nationalism, conspiracy theorists, normalizing political violence, proliferation of paramilitary groups, and ethnic resentment, which all contributed to the rise and takeover of the Nazi Party. It seemed like the foundation of the Weimar Republic was on shaky footing even to begin with. It was a parliamentary political legislation with a representative electorate consisting of chiefly social democrats, liberals, central, and then conservative parties. It was a fractured coalition from the onset. It was also an extremely fractious time during the inception of the Weimar Republic, with each political group having their own paramilitary, and there were siloed off worlds of party propaganda. The Communist Party was becoming very popular, especially in the context of the Bolshevik Revolution in Russia. The Communist Party within Germany wanted the same thing that the Bolsheviks did in the Russian Revolution, which was a vanguard revolution and the overthrow of a monarchical government. The German nationalists at this time, were conservative, and they wanted the return of Bismarckian monarchy Reich. It's a myth that the Weimar Republic was on its way to being a healthy and stable democracy. It was birthed and reared within boiling political turmoil, which proved fatal for the Republic. It was very far from achieving stability right from the get-go. So this book covers a small portion of World War I and mostly deals with its aftermath. Two major contributors to forming the Nazi Party came as a consequence of World War I: hyperinflation and conspiracy theorists. The Weimar Republic spent when it had no assets to keep their own economy afloat and also to pay for war reparations. The hyperinflation at this time is really mind-boggling to even comprehend. So the world is going into a global inflation right now, but it's child's play compared to what was happening in Germany at this time. Here's some perspective. The mark, right, their currency, it went from about 10 marks to $1 to 4 trillion to $1. Yeah, 10 to 4 trillion within a few years. Prices for something such as bread changed every hour. I can scarcely imagine the type of psychological trauma and scarring that this would cause to a people. All of this trauma naturally leads to tons of scapegoating. And then, enter anti-Semitism, which was alive and well, but it was mostly fringe at that time. There was a stabbed in the back conspiracy that started to proliferate, blaming some sort of clandestine cabal of Jews for Germany's World War I defeat. The, infant Nazi party at this time was still extremely unpopular. This is in the 1920s. And they didn't start these conspiracies, but they helped nurture and consolidate them into more palatable messaging. Now you pair this with leftist extremism happening at the same time. The Bohemian socialists started to take over Bavaria and even declared it to be a social state. The Bolshevik regime was even started in Munich and took orders from Lenin with its own paramilitary group. The Marxists and communists seemed to truly desire what people feared that they did, a violent revolution. They really there were Marxists and communists in Germany at this time that wanted a violent revolution, just like the Bolsheviks. So they were a real threat at the time. This is all happening while the Social Democratic Party enjoyed wide support and seemed to take comfort and even be pacified by the gentilism of the law and the Republic. But it seemed like the Social Democrats were way too short-sighted and too politically brittle to understand the ultra-nationalist protest backlash that was decades in the making, that was coming like a tidal wave. So then you enter the rise of Hitler, who came to prominence not because he was an eloquent speaker, but because he was a masterful propagandist. The Nazi Party was still on the fringe in the 20s and the late 20s, but started to consolidate into an ethos that consisted of anti-establishment, anti-republic, anti-democratic, anti-Semitic, anti-Marxist, and anti-communist. They were the party of protest. They were also a contortionist party, crafting rhetoric to meet and galvanize its audience whenever it needed to. It ultimately was a party that stood for very little principle other than achieving power. They were a party of deep nihilism. They even borrowed socialist rhetoric, and at one point called themselves Nationalist Socialists. And in a way, they were a brand of socialism, although a highly ethnically pure and xenophobic and ultra-nationalistic version of socialism that was very different from Marxism and communism then and now. Some people very incorrectly say that the Nazi Party was a communist party, and it was not. It had socialist, I think it had socialistic aspirations for its own ethnic group. So anyway, inspired by Mussolini's coup in Italy, Hitler tried the beer hall putsch thing, which didn't go over very well. He was arrested. He went to prison. He wrote his stupid book. And then the Nazi Party was actually made illegal at that point, which tells you how effective censorship was for that. The Nazi Party was starting to build a pretty good infrastructure, but was still fringe. They got exactly what they needed to catalyze them into popularity, which was the Great Depression. The communists surged during the Depression and were a fairly violent and extremist group who were more focused on seizing power away from the Social Democrats. The left-wing infighting made everyone who politically mattered at this time kind of blind to the potential of the Nazi Party. And then the Nazi Party got very serious about legally taking control of the country. They continued to streamline their propaganda and their messaging and started to seize more of the voting electorate. They made enormous electoral gains in 1930. Although they never enjoyed a majority, ever. The party then gained even more seats and became the dominant party along with the communists, both of whom wanted to destroy the parliament. It was the normalizing of political extremism that made the republic crumble. The Nazi Party became the rainbow coalition of political discontent. As the Nazis gained more momentum, they refined their messaging and soared with popularity, which included their deeply anti-Semitic position, which had become even more fortified by the early 1930s. So Hitler was finally sworn in as the Reich Chancellor, and that was kind of the beginning of the end for the Republic. He used the emergency powers of the Republic to effectively seize control of the government and begin a form of martial law. With his paramilitary groups, the Brown Shirts, the SS, the Stormtroopers, they were all well organized and ready to seize the day. So the paramilitary groups that had been around for a decade or more were then just they just swooped in. And then all it took was the Reichstag fire, which the author agrees was a lone wolf communist terrorist who started it. The Reichstag fire decree gave Hitler the excuse he needed to, just get rid of, expunge the political landscape of all of his political enemies. And the enemies were many: Marxists, communists, Catholics, intellectuals, musicians, artists, homosexuals, transsexuals, pacifists, scientists, and of course Jews. The Dachau camp was started early on as a place to banish Nazi political enemies. Somewhere by 1933, Germany became a true one-party state. It happened legally and with the consent of a large part of the population, probably around 35%. Social Democrats and communists were arrested, tortured, and murdered. The Nazi paramilitary had free rein to wreak terror and havoc and violence literally everywhere, and they did so with impunity. The judiciary became highly Nazi sympathetic. Under the guise of fighting, quote, cultural Bolshevism, book burnings became routine, and eventually the burning of bodies became routine and mundane. And we know how the rest of the story goes. So this book is, it's the story of the rise of Nazi Germany. And I would like to say that it sounded like it happened in a far away and distant time, but the truly alarming thing about reading this book was how familiar the political turmoil, the normalizing of political violence, the dehumanizing of political enemies, and ultranationalism sounds to my ears today. So, if you've listened to my podcast, you know that, I definitely think we're in a time of neo-fascism. So, what I'm describing here, Nazi Germany, this was a fascist state. It's a right-wing, it's conservative, and it's a fascist state. You see people that try to argue otherwise, but it's just not true. The reason the Nazi Party was right-wing is that it was conservative, right? It wanted to go back to Bismarck, like a Bismarckian almost monarchical rule with ethnic purity, right? That's conservative. That is extreme conservatism, and it's right-wing conservatism. Like, let's call it what it is. I'm not saying right-wing and all conservatism is bad or evil, but that's what this was. And at the same time, there was left-wing left-wing extremism going on at the same time. You had left-wing revolutions happening in Germany and later, and in China, which were also protests against monarchical rule. And these are awful regimes, right? One of the problem is, I don't know if I've talked about it before. So there's something called horseshoe theory, which is both political ideologies. Once they go to their extremes, they start to appear the same. And I think it's true. A lot of left people don't like horseshoe theory because they say that it's funny. People it all depends on your perspective. But I talk to people on the left, that would call themselves leftists or socialists or communists, and they think all, tyranny is right-wing. And you hear it from the other side. People on the right, they say all tyranny and it's all left. That's what left-wing is. Just throw that all out, for my opinion. It's single-party rule, right? And I've said this before. It's single-party rule. There's the problem. When one party rules, that's tyranny, right? And I think many ideologies do lead that way. So I do think there is some merit to horseshoe theory. But anyway, this book, we're seeing a lot of troubling things, a lot of right-wing extremism. There's left-wing extremism going on right now. For me, it's asymmetrical. The problem is it's asymmetrical. I think we have unbalanced right-wing extremism going on right now, and we're seeing it with the proliferation of conspiracy theories, the proliferation of paramilitary groups, the proliferation of political violence, the normalizing of political violence, the dehumanizing of political enemies, and then just unbelievable fractured political landscape, right? It's getting more and more fractured in American politics and elsewhere, right? And there's many reasons why this is happening. Many of the reasons are economic. A lot of them are cultural as well. Now, it was much worse in the Weimar Republic than it is right now. Way worse. The paramilitary groups, every political party basically had a paramilitary group in the Weimar Republic, right? We don't quite have that right now, but we're getting there. It's getting close. Now, I'm not like a doom and gloom person. I'm not saying it's something like that is inevitable, but the warning signs are very clear, in my opinion. They're right on the table what's going on, and neo-fascism is happening And, I think we should all be alert and be aware of our own susceptibilities to propaganda and of extremism, of political extremism. And it's corrosive and it's bad. Both sides of political extremism is bad. And it's worse on the right now. Okay? It's worse. It's asymmetrical. It's bad. Anyway, I'll leave that at that. I'll end up today. I'll close this off. Email me at icudoctorecmo@gmail.com, and then my TikTok handle is icudoctor. Thank you for listening.